Good morning, everybody. Thanks for being here. It's really nice to be here in Taiwan. I've been here for about a week, see family, and it's really nice to see you all here. So we'll get started. So I'm going to talk mostly, so in this session, probably 2/3 I will talk about SBRT for prostate cancer, and about 1/3 I'm going to talk about SBRT for kidney cancer, primary renal cell carcinoma. Just so I know, how many people here offer SBRT for prostate cancer? Okay, and how many people here offer SBRT for kidney cancer? Great. Okay, so hopefully I'll be able to present some information and maybe a couple of cases, and also I try to be very practical, so I also want to talk a little bit about technique for SBRT for both of these cancers, and hopefully there's time for questions as well. So I'll start with SBRT for prostate cancer. I think SBRT for prostate cancer now has a lot of good prospective clinical trial data, and I think a lot of good phase 2 data, and also some phase 3 clinical trials that have been published. So I think the data for SBRT for prostate cancer is very strong, and I'll go through some of these trials. I think the strongest phase 2 data for SBRT in prostate cancer is this study published by Kishan in JAMA Oncology from about 3 years ago. This paper, so SBRT for prostate cancer started about 10, 15 years ago, and many hospitals were doing phase 2 trials on their own. And this paper combined 10 phase 2 trials together, so then they can have a large sample of patients and look at long-term outcomes. So this is a pooled analysis of phase 2 trials from 10 different institutions. There's a total of 2,100 patients combined in this paper. And I think that the published literature has mostly low and favorable intermediate risk cancer patients. So in this particular paper, there were 1,100 low-risk patients, 692 favorable intermediate risk, and really in the literature, there's not very many unfavorable intermediate risk or high-risk patients. But this particular paper, 1,100 low-risk, 692 favorable intermediate risk. And most of these patients received SBRT only. Only 5% received ADT and a short term of ADT. So mostly SBRT only. And these were patients who were treated between 2000 and 2012. And I think this is a really good paper because there's good long follow-up for these patients with a median follow-up of 6.9 years. So I want to just sort of go over the results from this paper. And what we can look at is the biochemical recurrence or cumulative incidence of biochemical recurrence. Because of the long follow-up, they were able to report 10-year results. And you can see that for SBRT, for prostate cancer in low risk, 10-year biochemical recurrence was 8.6%, which means that more than 90% of patients after SBRT had no recurrence at 10 years. I think that's a really good number. For favorable intermediate risk, the recurrence was 13.5%. And for unfavorable intermediate risk, 18.9%. I think these numbers look very good, and certainly these numbers for biochemical recurrence at 10 years look very similar to other types of radiation that we offer, similar to IMRT, similar to brachytherapy. I think it really does show that SBRT for these patients seems to be very effective. Now, distant metastasis, the numbers are also very low. For low risk, 10-year distant metastasis was 0.5%. And also very low for favorable and unfavorable intermediate risk. So it seems like SBRT works very well to control the cancer at 10 years for these patients. And this is prospective data. I think one of the things we worry about for SBRT, which is high dose per fraction, is we're worried about late toxicity. We're worried that maybe 5, 10 years later, there's going to be a large number of patients with late toxicity. So I think this paper also addresses that question. So if we look at urinary toxicity, grade 2 urinary toxicity acute was 9%, and I think, again, very similar to brachytherapy, very similar to IMRT. Grade 3, grade 4 was 3% acute. And if we look at late toxicity, the cumulative incidence at 10 years of urinary toxicity, 13% grade 2, 3% grade 3 or 4. I think very similar to IMRT toxicity and certainly not more. If we look at GI toxicity, acute GI toxicity, grade 2, 0.6%. Grade 3 to 4, basically one patient. And at 10 years, late GI toxicity was 4.5% grade 2 and 0.4% grade 3 to 4. And these are patients who were treated 10 years ago. And I think with SBRT, no space war, I think the late toxicity rates from SBRT also seem to be very good. Now, if we look in more detail on what kinds of toxicities patients had, for urinary, there was 4 patients who had acute urinary retention. So during SBRT, they developed urinary retention and needed a Foley catheter. That's 4 patients out of 2,000, so very low numbers. I've been doing SBRT for almost 15 years. I've never had a patient who needed a Foley catheter during treatment, so it's very rare. There were 17 patients who had late urinary retention and required a TURP surgery. And 17 out of 2,000 patients, pretty low rate. Hematuria, 1 patient acute, 12 patients had late hematuria out of 2,000. 7 patients had a stricture and needed a dilation of the urethra. So I think these are reasonable numbers for toxicity and again, very similar to other types of radiation. Rectal bleeding, 5 patients had late rectal bleeding out of 2,000. 1 patient had a fistula, but this patient also has a history of diverticulitis, and so if a diverticulitis caused a fistula or radiation, we don't know. But these are certainly very similar types of toxins that we see with all types of prostate radiation. So SBRT doesn't seem to cause any more toxicity than other treatments that we give. So my take on this particular paper, I think SBRT is highly effective and safe. Again, most of the literature has patients with low and intermediate risk prostate cancer, and there seems to be no increased late toxicity through 10 years of follow-up, and probably not beyond 10 years also. Next, I want to talk about 2 phase 3 randomized trials for SBRT. I think these are also very informative. The first phase 3 trial is Hypo-RT-PC. This was a trial that was published in Lancet in 2019. Oh, you cannot see my arrow. Okay. So this was published in Lancet in 2019. This is a large trial with 1,180 patients, mostly intermediate risk, so almost 90% intermediate risk. They were treated between 2005 to 2015. This is a long time ago, and mostly they were treated with 3D conformal radiation, not even IMRT. But I think this is an important trial because it compared conventional fractionation, 78 gray and 39 fractions, to a really ultra hypofractionation, 7 fractions, 42.7 and 7 fractions. They gave it 3 times a week, which is 2.5 weeks. And I think this is important for biology. It shows us whether the biology of conventional fractionation and ultra hypofractionation works the same to control the cancer. So I think this is a very important biology randomized trial. The treatment was prostate only, no hormone therapy, so they only compared the radiation effect. And at the time of this publication, there was a 5-year follow-up, median follow-up. So what this trial showed, this is failure-free survival, which is basically recurrence. It showed that there was really no difference at all between conventional fractionation, which is 39 treatments, versus 7 treatments. So it really shows to me that biology in prostate cancer is the same, whether you give 39 in 2 gray per fraction or you give something much shorter. This is 6.1 gray per fraction times 7. Really, the biology is the same through, you can see 10 years of follow-up on the bottom. Through 10 years of follow-up, there's no difference in recurrence in these 2 fractionations. So it seems to me that hypofractionation or ultra hypofractionation works very well. They also looked at quality of life, which is looking at side effects between conventional and hypofractionation. And this is urinary side effects. And you see that really through 6 years of follow-up, the urinary side effects is pretty much the same. between 39 fractions and 7 fractions. And then here is GI. This is bowel quality of life. And you do see that for GI, the hypofractionation had a little bit higher short-term side effects. This is during treatment. But then for long-term follow-up, it's pretty much the same between the two arms. And this is, again, a randomized trial. And then for sexual function, it was the same between the two arms. So this is also another trial to demonstrate that I think ultra hypofractionation, or the short regimen, really is very safe with long-term follow-up. So my take on this trial, I think for patients with mostly intermediate risk cancer, it was 89% intermediate. For patients with intermediate risk cancer, I think conventional fractionation, 2 gray per fraction, 78 gray and 39 fractions, and ultra hypofractionation in 7 fractions, equally effective. The disease control is exactly the same through 10 years. So biologically, I think this is pretty much SBRT is equally effective as conventional fractionation. Ultra hypofractionation had more acute GI side effects during treatment, but this was during 3D era, and maybe with IMRT, VMAT planning, or maybe with SpaceOAR, maybe there's no difference, but certainly there's no long-term difference in side effects in the two arms, urinary, GI, or sexual function. So again, it seems like the ultra hypofractionation is very safe and shown in this randomized trial. So the second randomized trial I'm going to present is PACE-B. PACE-B is a randomized trial that was just published in 2022. This was 844 patients with low or intermediate risk prostate cancer, and they were randomized to IMRT, and IMRT could be either conventional fractionations, 78 gray and 39 fractions, or moderate hypofractionation, which is 62 gray and 20 fractions. So either one could be used for the IMRT arm, and the SBRT arm was 5 fractions, 40 gray to the CTV. CTV is prostate, and then 36.25 to the PTV, which is an expansion around the prostate. So randomized trial comparing IMRT to SBRT. This is a more modern trial, patients treated between 2012 and 2018. No hormone therapy, radiation only. And I want to show the side effects that were published in this paper. These are all the urinary side effects they looked at. And what you could see, again, there's 2 arms that are here. So if we look at grade 2 hematuria, is pretty much exactly the same in the 2 arms, and grade 2 hematuria is very low. If we look at grade 2 or higher dysuria, which is pain, also the same and low. If we look at grade 2 frequency, frequent urination, SBRT had a little bit higher frequency at about 15 months, but then afterwards, it was the same in the 2 arms. So SBRT seems to have a bit of a urinary symptom flare at about 1.5 years. That gets better. If we look at urinary incontinence, that's the same in the 2 arms. If we look at the urinary urgency, SBRT has a little bit of a flare at 15 months, but then the same after. And then retention is the same. So it seems like in this randomized trial with pretty modern type radiation, the urinary side effects are very similar between IMRT and SBRT, with a couple of exceptions that's temporary. Here is a plot of the GI toxicity, so bowel toxicity. And what you see here, this is grade 1 bowel toxicity. This is grade 2 and grade 3. Actually, what you see here for grade 1, which is about 30% of patients, the red arm is actually the IMRT arm. IMRT in this trial actually had higher grade 1 toxicity, and SBRT had lower grade 1 GI toxicity. Grade 2 and grade 3 were the same. So in this randomized trial, my take on this is that both IMRT and SBRT are safe and cause low rates of GI and GU toxicity through 2 years after. SBRT causes more urinary urgency and frequency at about 1.5 years, so there's symptom flare. But IMRT actually causes more GI side effects. So again, I think all the data seem to suggest that SBRT is very safe and causes similar side effects as IMRT. So I think that's a lot of the data that really support SBRT as a standard treatment for prostate cancer. There's a lot of phase 2 data. There's at least 2 randomized phase 3 trials really showing SBRT is effective and safe. And so next I want to talk about how do we do SBRT? So how technically do we actually do this? I'm going to show this slide, which is, you cannot read this, but I'm going to just try to make a point. This is the phase 2, the combined phase 2 paper that I showed in the very beginning from the Kishan JAMA Open 2019. Remember that that paper combined 10 phase 2 trials with 2,000 patients together. What I'm showing here is that in those 10 trials they combined, every trial had a different way to do SBRT. So as somebody who does a lot of prostate SBRT, every hospital kind of does SBRT for prostate a little bit different. So there's different doses people gave, 7.25 times 5, 8 times 5, 9.5 times 4, so 7 times 5. Everybody gave a little bit different dose for prostate SBRT. There's no one way to do it. Lots of people do it different ways. Also, the different trials had different prescriptions, 95%, 100%, 95%, different prescription coverage, and also different expansion for PTV, 2 millimeters, 3 millimeters, 5 millimeters. So everybody does SBRT a little bit differently, and there's not one standard way to do it. And that's okay. I'm going to show a little bit about how I do it. Mine is one way out of many, but I want to show sort of how I do it. So I do SBRT a lot, and these are the patients that I think are good for SBRT based on the published papers. Again, I think most of the studies have low or favorable intermediate risk cancer. I think that's where most of the data are in the literature. So these are the patients that I would choose. Unfavorable intermediate risk or high risk, I don't think there's enough data, so I don't offer SBRT to those patients. But I do it for these patients. And actually for these patients, for low risk in the US and low risk, we often offer active surveillance as a first option. But for favorable intermediate risk, I usually offer treatment. And SBRT is actually my first treatment recommendation for favorable intermediate risk. That's actually my favorite treatment because I can treat these patients in 5 fractions, which is 1 week. And I don't want to treat them with 5 weeks or 8 weeks of radiation because I think 1 week is just as good. So SBRT is my first recommendation for favorable intermediate risk patients where I practice. I don't like patients who've had a prior TURP before SBRT. So if they have prior TURP, I don't offer SBRT to them. There's a little bit of data to show that TURP patients may have a higher risk for urinary side effects, hematuria. And so just to be very safe, I don't offer TURP patients SBRT. My prostate size limit, I like the prostate to be less than 100 cc's, and almost every patient is less than 100 cc's, but that's my size cutoff. And of course, no contraindication to radiation for patients who get SBRT. And in terms of sort of technically how I do it, I offer this dose, 7.25 times 5. Again, there's lots of different doses in the literature. I think 7.25 times 5 is probably the most common in published papers. That's what I use for my patients. I give treatment every day. Some people do it every other day. Some people do it twice a week. I do treatment every day, so they finish Monday through Friday. They finish in 1 week. And that's what I do. I use fiducial markers for image guidance. I like to push SpaceOAR in my patients or Barrigel. I think that can reduce the rectal dose. It's not absolutely necessary. I did SBRT for prostate cancer for 10 years before there was SpaceOAR, and it's very safe. I like to use SpaceOAR, but it's not absolutely necessary. For simulation, I like to put them in the vac lock. I use a Foley catheter for simulation so I can contour the urethra and calculate urethra dose constraint. But I only use a catheter for simulation. I don't use a catheter for treatment, just for simulation. I like the bladder to be comfortably full, not very full, but comfortably full. I like the rectum to be empty, and I like them to use a daily enema to empty the rectum. So again, I think that minimizes the rectal dose. For CTV, I contour the prostate and about 1 centimeter of seminal vesicles. For PTV, I expand 5 millimeters. And for posterior, I probably do 3 millimeters posterior. That's what I do. And the image guidance, I do cone beam CT. Cone beam CT allows me to see the bladder and the rectum every day, and I like to check that, and then line to the fiducials. Yes? Yeah, so there's different ways to do it. I like to empty the rectum because I think that's the least dosed to the anterior rectal wall. And so it pulls it away. I think if you do a rectal balloon or extended rectum, the anterior rectal wall is getting full dose. And maybe that's okay, but I like the anterior rectal wall to actually get less than full dose, so I like empty rectum. No. Yeah, that's a really good question. I don't think there's been a comparison of rectal side effects between a full rectum versus an empty rectum. So yeah, it's a good point. Now, I think there's also many different dose constraints out there, and there's not a single dose constraint that everybody uses. What I'm showing here, again, you don't have to read this, and hopefully it's in your slides. What I'm showing here are the dose constraints from the NRG trial. So NRG has done several clinical trials with prostate SBRT, and this is the most recent prostate SBRT NRG trial dose constraint for rectum and bladder, urethra, femoral head, penile bulb. And so I think using NRG dose constraints is reasonable, but every institution has slightly different dose constraints people use. So I think SBRT to me is very standard. I offer it very often. I think there's a lot of good data. In the next part of this, I'm going to talk a little bit about the future direction of how SBRT is changing. And I think that one way it's changing is to try to boost a tumor that you can see in the prostate. And there's actually a little bit of data here, and there's more trials on this idea. So the paper that's been published on this was published in 2020. It's a phase 2 trial called HypoFlame. They treated 100 patients with intermediate or high-risk prostate cancer, and all of these patients had at least one tumor you can see on MRI. So if you see a multiparametric MRI, if you can see a tumor on multiparametric MRI, maybe you can boost that to a higher dose with SBRT. So what they did in this trial was they did 35 gray and 5 fractions, 7 times 5, to the whole prostate, but they wanted to simultaneously integrate it with SIB to the tumor to 50 gray if they can. So you treat the whole prostate at 35 gray, but if you can see a tumor on MRI, try to boost it to a higher dose. As much as you can, because sometimes that tumor is very close to urethra or very close to the rectum, so maybe you cannot take it to 50 gray. So what they did is they want to take it to 50 gray as much as possible, but you have to respect the OAR dose constraints. So take that tumor as high as you can, but do not exceed the urethra dose, do not exceed the rectum dose, do not exceed the bladder dose. So that was how they did the protocol, and I think it's very reasonable. You want to treat the tumor to higher, but you don't want to cause more toxicity. And what they were able to show in this 100 patients is that they had a medium GTV, which is a tumor they could see. The medium GTV in this trial was 2.3 cc's, and they couldn't take it to 50 gray. The median dose they could take it to was 44.7 gray. So again, you take it as high as you can, but you don't want to exceed the dose to the urethra and rectum and bladder. And this is a paper that looked to see whether this way to do SBRT is safe. So the primary outcome of this paper was acute GI and GU toxicity. And they were able to show that this is very safe. So this is their plot of GU toxicity. This is during treatment. This is 90 days and 6 months. So short-term GU toxicity. This is grade 1. So about 70% of patients had grade 1 GU toxicity during treatment, but then that improved after. Grade 2 toxicity was 11% at 90 days, and there was no grade 3 toxicity. I think these numbers are very similar to IMRT, and so this is sort of what we expect, but it seems like boosting, a micro boost to the tumor does not seem to cause more side effects. And then this is the GI toxicity plot. Again, grade 1 GI toxicity during treatment up to 30%, but it improved after. Almost no grade 2 or grade 3 GI toxicity. So it seems like this idea of boosting, using SBRT to the whole prostate and then boosting to the tumor inside, certainly seems to be safe. There's now more trials to see whether this is more effective for cancer control. So my overall conclusion on the first part, which is prostate SBRT, my overall conclusion is I think prostate SBRT in the last 10, 15 years has changed from offering 38 to 40 fractions, 8 to 9 weeks. There's now about 9 randomized trials to show that moderate hypofractionation, 4 to 6 weeks, is safe and effective. So it's changed from 8 to 9 weeks to moderate hypofractionation. And I think there's more and more data on SBRT. I really do think that SBRT, which is offering patients 1 week or maybe 2 weeks of treatment, is certainly, I think, here now, but also, I think, more common in the future. So this is really changing. And I think prostate SBRT is very well established with lots of data for low and favorable intermediate prostate cancer. Most of the data are in this group. I think it's safe, even without SpaceOAR, and maybe even a little bit safer if you put SpaceOAR or Barrigel. I think when you treat a patient from 8 weeks down to 1 week, there's a big benefit because it's more convenient to the patient and also a lower cost. So I think this is good for the patient to shorten treatment from 2 months to 1 week. It's good for the patient and just as effective. And I think there's more and more randomized data that will be coming. There's more trials in phase 3. We wait a few more years, there will be more and more randomized trials that will be published. Even though the current data support low and intermediate risk cancer, NRG is doing a high-risk phase 3 trial, so NRG GU13, I think will be open this year, and is comparing SBRT versus conventional moderate IMRT for high-risk cancer. I think that's where really, I think, an important trial, and in a few years we'll have data to see whether SBRT could be used for high-risk cancer as well. So that's prostate. I want to stop here to see if anybody has any questions on prostate SBRT. Yes?
Dr. Chen, is there any protocol for your bladder freeing? You say you will make the patient feel comfortable bladder.
Yes.
So is there any protocol means they have to empty their bladder before?
Yeah. This is what I do. Every hospital does SBRT and bladder a little bit differently. What I do is I tell the patient, so some hospitals will have the patient drink a lot of water or drink coffee. What I do is I tell the patient, do not empty your bladder for 90 minutes before treatment. So if your treatment is at 9:30, don't pee after 8 o'clock. So that's what I do. And usually people can do that for an hour and a half. So that's comfortable and it's not empty. So that's what I do.
Thank you.
Yes?
Prostate cancer patient receive surgery and with biochemical failure.
Okay. So the question is, do we use SBRT for prostate bed radiation? Patients that had a prostatectomy that have a biochemical recurrence. We treat the prostate bed for salvage treatment, and can we use SBRT? There's more and more data on that. I don't use that just yet. I don't think there's enough data yet. And so I think there's enough data to show that 5 or 6 fractions to the prostate bed is probably safe, but I want more data. I want more phase 3 data. So I don't have that phase 3 data. I don't use it just yet. Other questions? Yes?
How do I treat for the urinary bladder comfortable full?
Yeah, urinary bladder comfortable full. What I do is I tell the patient, don't use the bathroom for 90 minutes before treatment. So that's what I do. And so if you don't use the bathroom for 90 minutes before treatment, I think that usually works okay. Now, of course, we do cone beam CT every day, and so the first day you can see if the bladder is empty or full. Sometimes you have to adjust and tell them to drink. But for most patients, 90 days, don't use the bathroom, usually works okay.
Okay. And another question about the STEMP study shows that oligometa is suitable to treat the primary tumor, may improve the the outcome.
Yes.
Do you consider the oligometa status is suitable for the SBRT?
Oh, that's a very good
Yes
question.
or not, and why? Thank you.
Yeah, that's a very good question. So for patients with oligometastatic prostate cancer, I think we should treat the prostate with radiation because STAMP shows improved survival. And you can, for the prostate radiation, you can use SBRT. Actually, we'll have a case in the GU case session on this. And so I will show the doses that we use. I think SBRT is an option.
For the recurrence prostate cancer, will we irradiate the prostate cancer with SBRT?
Right. So for recurrence, I don't use SBRT to treat the prostate bed for recurrence. I do not. Some people do. I think there's a little bit of published data on that. It's probably safe, but I don't think there's enough phase 3 trials, and so I don't use SBRT for prostate bed yet. I think for prostate bed, for recurrence after surgery and salvage radiation, I think there's going to be a phase 3 trial being published maybe in the next year, looking at moderate hypofractionation. So, historically we give 66 gray and 33 fractions. That's what I usually use for prostate bed. There's going to be a phase 3 trial to use moderate hypofractionation, 25 fractions. And that's an NRG trial that will be published probably in the next year, showing that I think moderate hypofractionation is safe and effective. So I think that's probably pretty good, moderate hypofractionation. But SBRT, I don't think there's enough data, so I don't use that.
But if it is not only a biochemical failure, you have seen a visible tumor on the MRI, will you boost with SBRT or?
For after surgery, yes, it's a very good question. So after surgery, if the patient has recurrence, and you can actually see a tumor on MRI in the prostate bed, I will take that tumor to a higher dose. So usually I would treat the prostate bed to maybe 66 gray. If I see a visible tumor, I would try to take it more than 70 gray. So but I still use conventional fractionation. I'll take it above 70 gray if I see a tumor. There's also a question back there.
I personally do not recommend to use the SBRT in the prostate tumor bed. May I ask if anyone from the audience agree the treatment? How do you identify your CTV? You know what I mean?
So in the prostate bed?
Yeah. Status post prostatectomy patients.
Yeah. No, I think there's, so I don't use SBRT for prostate bed either, but I think there are people who will contour the same CTV. You contour the same prostate bed CTV, and then you just use higher dose per fraction. There are some people doing that, but not very many, and I don't do it. No, that's right. No, I think when you're treating the prostate bed, most of the time you're just treating an area. You cannot see the tumor. That is true. But I think some people still treat the same area just faster. And maybe that's good. But again, I don't do it. I don't think there's enough data. Let's move on. I want to talk about kidney SBRT also. So, and I have about 10 minutes, which is great. In kidney, there is less data. And so I think this is a newer area and maybe not exactly as good as prostate. I think the best data for kidney SBRT is this paper that was published in Lancet Oncology last year. This is also a pooled analysis from multiple institutions, a pooled analysis of 12 institutions in 5 countries. And they were able to pool 190 patients with primary RCC, kidney cancer, treated with SBRT only, no systemic therapy. Of course, with kidney cancer, the first treatment usually is surgery. And so these SBRT patients are older, most likely not able to have surgery. And so 75% of patients in this study medically inoperable, could not have surgery. And some of the patients only had 1 kidney, so also not good for surgery. So these are all patients who are older, probably couldn't have surgery, and that's why they had SBRT as the alternative. Interestingly, the tumor in this study is pretty big. The median size is 4 centimeters, which means half the tumors are bigger than 4 centimeters. So it's actually pretty big tumors treated with SBRT. So if we look at how effective SBRT for kidney cancer, it's actually very effective for SBRT. And now with conventional fractionation, RCC is radioresistant and probably doesn't work. But with high dose per fraction, it seems to work. So this paper was able to show 7-year results, 7-year outcomes, and local failure, which is the kidney cancer growing, is less than 10%, which means that we can use SBRT to treat the primary kidney cancer and with more than 90% local control, which is very good. Freedom from distant failure. So 81%, so 19% of people had distant failure, which means that you can control the local disease, but some patients have metastasis that you cannot control. Cancer-specific survival was 92% at 7 years. But it seems like SBRT for primary RCC can control the local tumor with a very high percentage. It's also very safe. So there was some grade 1, grade 2 toxicity, which is mild, some fatigue, a little bit of nausea, chest wall pain, I guess if it's close to a rib, skin toxicity only 2%, mostly grade 1, grade 2. There's only one patient with a grade 4 toxicity, gastritis. And for this patient, I think they had grade 4 ulcer because the dose to the small bowel was 54 gray in 4 fractions, which I think is too much. But overall, this is the only grade 4 toxicity that we're seeing in the entire series. So very safe. Chronic kidney failure was 7%, which is not surprising. Even if you take a patient to surgery, if they have a nephrectomy, kidney failure is probably more than 7%. But SBRT seems to be very safe for RCC and seems to be very effective. They looked to see if it was different by bigger or smaller tumor size by 4 centimeters. Local failure is pretty much the same, whether it's bigger or smaller tumor. Cancer-specific survival, pretty similar, and progression-free survival, pretty similar. So it seems like SBRT is effective for both bigger and smaller kidney tumors. I want to show a case of a patient that I treated. So you can see in this image here that my patient had a RCC here. And this is an older patient, unfortunately. So she was 83, and she had that known kidney tumor since 2006. And it was 2.6 centimeters. Now, because of her age, urologists could not do surgery and recommended active surveillance. But I think they waited too long. So in 2008, it grew to 2.8, and then it really grew faster, 4.7. 5.5 is when the patient came to see me. The urologist doesn't know about SBRT as an option and couldn't do surgery, so just kept watching it. And finally, the patient found me at 5.5 centimeters. She was 89 years old when she saw me. We did a biopsy of the tumor. It showed RCC grade 1 to 2. 5 minutes. So she's pretty healthy, 89-year-old, stage 1 colon cancer that had surgery 2016, but no recurrence. Hypertension, hyperlipidemia, pretty healthy 89-year-old. So how did I do SBRT? Well, the paper that I just showed you was a combined analysis of 10 different institutions, or 12. And everybody does SBRT differently. RCC SBRT, some people do single fraction, 24, 25, 26, single fraction. Some people do 3 fractions, 36 or 42. So this is 12 times 3 or 14 times 3. Some people do fractions, some people do 10 fractions. There's no standard. We still are trying to figure out what dose to use, but there's all different kinds of variability. Again, you can also see this in the paper, different prescription isodoses, different expansions. Everybody does this a little bit differently, and that's okay. We're still trying to figure out how to do this. But this is what I do. I use 13 times 3, so it's between 12 and 14. I use 13 times 3, SBRT, IMRT, VMAT. I do daily treatment, so 3 days. That's what I do. VAC lock, I do a 4D CT to see the kidneys moving. Sometimes it does move, so we want to know that. I do a 3 millimeter expansion around the ITV, but I shave it off the bowel. I'm really scared about high dose to the bowel, so I shave it off the bowel. And the image guidance I use is cone beam CT, and I have fiducials in the tumor. This is the patient's plan. You can see 100% isodose. This is 70% isodose, really not touching the bowel. And then, so it's very, very tight plan for this 89-year-old patient. So I saw her. She finished treatment without any acute toxicity, very safe, very well tolerated, 89-year-old patient. I saw her about a year later. The tumor shrunk from 5.5 to 4.8. In my experience with kidney SBRT, the tumor does not disappear. Local control means the tumor shrinks a little bit and doesn't grow. So you don't expect the tumor to shrink. That's in my experience. The kidney function is very good. Before treatment, her kidney function, creatinine was 1.1. When I saw her a year later, she was 1.3, doing very well. So I think this is really a reasonable option. This is my last slide. So kidney SBRT actually is in the NCCN guidelines. SBRT may be considered for medically inoperable stage 1 kidney cancer or stage 2 and 3. I think there's good data for stage 1 kidney cancer, and I think this is a reasonable option for patients who cannot have surgery. I think SBRT is a promising treatment for primary RCC and should be considered for patients who cannot have surgery. So sometimes urologists, if they cannot have surgery, they don't think about radiation, but they really should think about radiation. This is a very safe and effective treatment. I think it's well tolerated. Respect bowel dose constraints. Bowel is what I'm scared about. If you shave it off the bowel, make sure the bowel's not too hot, I think it's a very good treatment for patients. That's my last slide. Yes? Yeah, that's right, I do. I use the same dose, 13 gray times 3, that's what I do. I think we need more data to see if we need to change the dose for bigger or smaller tumors. We don't have enough data yet, so I use one dose right now. Yes?
Would you please tell us the detail of the reduced insertion for the RCC tumors?
Yes, and this is probably the last question because of time. For fiducial placement, I use my interventional radiologist. Interventional radiology with CT guidance, they use needles. They usually use 3 fiducials to put it around the tumor, up, right, left. CT guidance is what I do. You can inside, but on the outside. Inside, but on the periphery is what I do. Not exactly in the middle. I want to see exactly the whole tumor movement. So that's what I tell my interventional radiologist, put 3, but on the periphery of the inside. We'll stop there. Yeah. Thank you very much, everybody.
我们休息时间到10:25，然后外面有那个 coffee break。那下一场是10:25开始。